virtual program by the KSOS Scientific Committee, and we have the 13th module today. So we have a case presentation from Government Medical College, Thrissur, Dr. Mushrifa, and Dr. Samyukta Sadashivan will be the mentor of today's program. And we are lucky to have Dr. Meenakshi, who is the Chief of Arvind Eye Hospital, Tirunelveli, to moderate the session. So with these few words, I hand over the program to Dr. Samyukta. Over to you, Dr. Samyukta.
Thank you, sir, for the wonderful opportunity. Let me introduce myself. I am Dr. Samyukta Sadashivan K, pediatric ophthalmologist and strabismologist, currently placed as assistant professor in ophthalmology, Government Medical College, Thrissur. So we know we are here for the KSOS virtual PG classroom module number 13. Dr. Mushrifa N.A., our junior resident, will be presenting a long case on strabismus today. And to moderate the session, we have on board with us the very eminent Dr. Meenakshi Ravindran, Chief Medical Officer and Head of the Department of Pediatric Ophthalmology and Strabismus and Refractive Surgery Services in Arvind Eye Hospital, Tirunelveli. With a distinguished career span of close to 28 years as a senior consultant in Arvind Tirunelveli, Madam's versatility has been recognized with numerous accolades for continuing her work in ophthalmology, be it academic, surgical volume, surgical training, community ophthalmology projects, and of course, research publications numbering close to 160 publications to date. Having been her student over the last decade, I'm sure that our residents will have a great session, an engaging session today. With that, I extend heartfelt welcome to Meenakshi Madam and looking forward to learning from you, Madam.
Thank you, Samyukta. So nice to see you as AP at Sure. So I'm sure that you're doing a good job, great job there. After doing our postgraduates, DNB here and fellowship, and I'm sure both of us will learn from this program.
Okay. Over to you, Mushrifa. You can share your screen.
Okay, madam.
The other residents can mute themselves for the time being.
Madam, is it visible?
Yes.
Can I start the presentation?
Yes, Mushrifa.
Okay, good evening, everyone. I would like to present the case of 30-year-old male from Palakkad who is a carpenter by profession. His presenting complaint is double vision and deviation of the right eye for the past 5 years. Coming to history of present illness, patient was apparently normal 5 years back. In December 2020, he developed sudden onset double vision following usage of mobile phone continuously for 4 to 5 hours for drawing as part of his work. His family members also noted sudden onset inward deviation of his right eye, which has been constant since then. The double vision resolved on closing either of the eyes. It was present for both distance and near. Images were horizontally separated to the same extent in all gaze positions. It was constant in nature. There is no history of diurnal variation, no history of adopting any specific head posture noted. There is no complaints of defective vision or ocular pain. There is no history of headache, vomiting, fever, seizures, or neck pain. There is no history suggestive of deviation of angle of mouth, weakness of limbs, tinnitus, vertigo, hearing loss. There is no history of difficulty in swallowing food or regurgitation of fluids. There is no history of any recent vaccination or COVID-19 infection prior to the onset of symptoms. Patient consulted a private eye hospital 2 years after the onset of symptoms. He gives history of Botox injection to the right eye. He presented to us in 2024 with persistent diplopia and ocular deviation. He was evaluated and taken up for squint surgery in June 2024. The recess procedure in the right eye was done after neuroimaging and neurology consultation. Postoperative period was uneventful with improvement of ocular deviation. He was advised other eye surgery but was lost for follow-up for about 6 months due to personal constraints. Coming to past history, There is no history of any similar episodes in the past. Birth history, antenatal and perinatal periods were unremarkable. There is no history of any developmental delay. There is no history suggestive of ocular deviation or patching or exercises or use of glasses in the childhood. There is no history of any sinus surgery or neurosurgery in the past. There is no history of trauma in the past. No history of diabetes mellitus, hypertension, dyslipidemia, coronary artery disease, or cerebrovascular accidents. Coming to personal history, he has mixed diet, regular bowel and bladder habits, sleep and appetite is not altered. There is no addiction. He is a carpenter by profession for the past 10 years and gives history of prolonged near work. Family history, there is no history of any ocular deviation in the family. And shall I proceed with examination?
In the history, so you have asked the relevant history. Can you go back? So why did you say that it is when the both eyes are open? What do you mean by that? Double
It is
vision
to
resolved on
classify
closing either of the eyes. What does it mean actually when you tell that?
It is to differentiate whether it is monocular or binocular diplopia.
Yes.
In binocular diplopia, on closing either of the eyes, the diplopia will be resolved. In monocular diplopia, on closing the affected eye, the diplopia resolves, but on closing the unaffected eye, the diplopia persists.
Okay. Any one or two causes of monocular diplopia you can tell?
Monocular diplopia, the corneal pathologies like corneal scars or severe astigmatism. In keratoconus, then if there is polychoria or large peripheral iridectomy done, or if there is lens subluxation or early stages of cataract, if there is macular pathologies like macular edema.
Okay. Okay. Good. Good. So, are there any conditions like where it can be present for near alone and not for distance or something like that? It's present for near.
Double vision can be present more in distant if there is lateral rectus palsy. If it is more in near vision, if there is medial rectus palsy.
Or sometimes, in a child, you can think of in accommodative ET, when it is
in accommodative
more esotropia, it will be more for near. Sometimes child can have this thing. Okay, if it is a child, this is not a child. Or suppose it's an exotropia, then patients usually, instead of saying as diplopia, they may say that when they go out in the sun, they close one eye. In intermittent exit, that is a very common complaint. Like they will not say there is a exotropia. They'll say they close their one eye when they go out in the sun. That is because of the deviation that's happening when they look at the distance. So a double vision is triggered, and to avoid that, the patient will close the eye, but it won't be told as diplopia. So these are some of the things we have to remember that. And okay, this is okay. Images or horizontally separated. I am glad that you asked that question to the patient because it helps us whether
it is committant or incommittant, whether there is if there is separation in any case in paralytic squint, the double vision increases on the affected muscle side.
Not always, depends. Okay. Okay, what do you mean by constant in nature? Why did you tell that?
There is no history of any diurnal variation. That is, in myasthenia gravis, the diplopia worsens towards evening due to fatigability of the muscles. So it is less in the by evening it will worsen.
Okay, so that is the main thing. A lot of times we have seen like patient comes in with restriction. Either adduction is restricted or abduction is restricted. It looks like a partial third nerve palsy with ptosis and everything. And then what test do you do? A simple test. For dilatation, ask the patient to close the eyes. When he comes back to you, everything would have disappeared. So that is called as a sleep test. Instead of hydrophonia, you can do this. The whole thing will change. Whole muscle will recover because you are giving rest to the eye. So it's good that you have asked these questions, which are relevant to this particular case also, because it's an acute onset esotropia in an
Young
patient. Okay. Next one thing you have told that is not having any specific head posture. You told its eye is deviated inwards, but no specific head posture. So that also suggests something that it is not a incomitant squint. It is not. It looks like a commitant
squint.
Okay. Go to the next one. Next slide you told. Yeah. Why do you want to ask these questions of headache, vomiting, fever, vaccination? Any idea? Swallowing food and all that is for?
In head, since this is an acute onset diplopia, we always should rule out if there is any signs of raised intracranial tension.
Very good. Very good.
And also whether there is any associations, whether there is any involvement of other cranial nerve involvement. And in recent vaccination and COVID-19 infection has shown demyelinations.
Yes. Actually, this is an adult patient, but if it is a pediatric age group, we do get a lot of cases of acute palsy following even the regular vaccinations, like following any pertussis DPT or following even MMR, all that we do get a vaccination, palsies, acute palsies, but usually they recover very fast. So that is one good thing that you asked all this. And COVID-19, of course, we had a lot of the infection as well as the vaccine caused some nerve palsies and acute graft rejections and the eye occlusions, all that we have seen both post COVID-19 infection as well as the vaccination for it. Okay? Okay. Okay, then carry on. I think so we will come to this Botox and all that later in your. Okay, right. Carry on with examination.
Coming to general examination, patient is moderately built and nourished. He is conscious and oriented. There is no pallor, no icterus, cyanosis, clubbing, no generalized lymphadenopathy or pedal edema. Skin, hair and nail is normal. No palpable thyroid gland swelling. Vitals examination, pulse rate is 74 per minute. Blood pressure is 126/80 millimeters of mercury. Sitting position, right upper limb. Respiratory rate is 14 per minute and the patient is ephebrine. Coming to systemic examination, nervous system, higher mental function is normal. Cranial nerve examination, cranial nerve 1, there is no anosmia. Cranial nerve 2, 3, 4 is dealt with ocular examination. Examination of cranial nerve 5, corneal sensation over the face is normal in both sides. Muscles of mastication is normal in both sides. Jaw jerk was brisk on both sides. Examination of cranial nerve 7, Bell's phenomenon is good in both eyes. Forced eye closure is normal in both sides. There is no deviation of angle of mouth. Cranial nerve 8, Rini is positive bilaterally and Weber is central. Cranial nerve 9 and 10 examination, uvula is central, gag reflex is present. Cranial nerve 11, shrugging of shoulder against resistance and turning of face against resistance is normal on both sides. Examination of cranial nerve 12, there is no wasting or fasciculation of tongue, no deviation or protrusion of tongue. Motor system, tone, bulk, power and reflexes are normal in upper limb and lower limb. Sensory system is normal. There is no cerebellar signs, no signs of meningeal irritation. Skull and spine is normal. Systemic examination, musculoskeletal system, cardiovascular system, respiratory system and gastrointestinal system was within normal limit. Coming to ocular examination, vision in the both eyes was 6/6, near vision N6, color vision was normal in both eyes. Cycloplegic refraction at 2/3 meter with homotropic 2% showed 1.75 diopter in the both horizontal and vertical meridian. Head posture is erect. There is no facial asymmetry. No abnormal head posture noted. No ptosis, no proptosis or inophthalmos. Coming to ocular movements, Versions and ductions were full and free in all directions. No nystagmus was noted. The 9-gaze image showed no limitation of movement in any direction. Coming to test for binocular single vision and stereopsis. Titmus flight test showed no gross stereopsis. And TNO test, the patient did not pass the first screening plate. Worthford dot test for distance was done, and it suggested that 5 dots were seen, and it suggested of uncrossed diplopia. Bagolini's striated glass test showed diplopia with no suppression. Coming to Hirschberg test, on shining the torch over the midline of the eyes, the corneal reflex fall over the temporal margin of the pupil, suggestive of 15-degree right esotropia. On cover and uncover test, on covering the left eye, the right eye moves temporally to take a fixation, and on uncovering the left eye readily takes a fixation and the right eye deviates nasally. In alternate cover test, it suggested that there is alternate esotropia with left eye dominance. Coming to measurement of ocular deviation with alternate prism cover test done in primary position for both distance and for near. Here a base out prism over the right eye with left eye fixing was done. It gave a value of 40 prism diopter esotropia base out, and for near 40 prism diopter esotropia base out. Alternate prism cover test was done in up gaze. It gave 35 prism diopter esotropia base out. In the right case, 35 prism diopter esotropia base out. In the left case, 40 prism diopter esotropia base out, and in down gaze, 40 prism diopter esotropia base out. Coming to diffuse light and slit lamp examination. Lid and adnexa is normal in both eyes. Conjunctiva is normal. Cornea, size and shape normal. It is clear. Normal sensation in all 4 quadrants in both eyes. Anterior chamber depth was normal. Iris normal color and pattern. Pupil is round 2 millimeters. Direct and consensual reflexes was normal. There is no RAPD. Lens was clear in both eyes. Coming to fundus examination, distant direct ophthalmoscopy showed red glow in both eyes. Media was clear. Disc normal size and shape. Well-defined margins. Neuroretinal rim is pink. Cup disc ratio is 0.3. ISNT rule was maintained. Peripapillary area is normal in both eyes. The AV ratio is 2:3. Examination of the macula showed foveal reflex was present with no evidence of torsion. Above findings were confirmed using 90 diopter lens. Visualized periphery was within normal limit, both eyes using indirect ophthalmoscopy. Coming to special test, diplopia charting using red-green goggles with red in front of the right eye and green over the left eye showed binocular uncrossed horizontal diplopia with equal separation on all gazes. Coming to summary, 30-year-old male who is a carpenter by profession with no comorbidities presented with sudden onset inward deviation of the right eye with associated binocular double vision following prolonged continuous near work 5 years ago. He had undergone a trial of Botox injection from elsewhere, following which there was no improvement. After evaluation in our center, squint surgery was done in the right eye 1 year ago with advice for other eye surgery, but the patient was lodged for follow-up for about 6 months. General and systemic examination was within normal limit. On ocular examination, visual acuity was 6.6 both eyes. Squint evaluation showed 15-degree alternating esotropia with left eye dominance. Prism cover test showed 40 prism diopter esotropia base out both for distance and near. There is no gross stereopsis. Anterior segment of both eye was within normal limit. Fundus examination was normal both eyes with no evidence of torsion. Diplopia charting showed uncrossed horizontal diplopia with equal separation on all gazes. Coming to diagnosis, It is alternating esotropia with left eye dominance, most probably acute acquired comitant esotropia, post squint correction right eye.
The whole presentation was very good, Mushrifa. You had covered most of the things and you were so confident in presenting the whole thing. So that I should appreciate that you had covered most of the things that is available. And so that is one thing. So can we go back to the examination part? Yeah. Just come to the next one. So what is this Hirschberg's test? So is it relevant to tell Hirschberg's test, and does it help us in any way, or which gives the best results? Hirschberg's test we rely more upon in which age group?
Hirschberg test can be done in children, but they should be cooperative enough.
Yes.
We cannot get we only get a rough estimate.
So what is the rough estimate like?
In Hirschberg test, we shine a torch.
Of course, it is at the pupillary margin. How much do you say is the
1 mm deviation gives a rough estimate of 7 degree, which is 15 prism diopter. So if it falls on pupillary margin, it is around 2 mm, that is 30 prism diopter deviation. If it is between the limbus and the pupillary margin, it is 60 prism diopters. And if it falls over the limbus, it is 90 prism diopter deviation.
So here in this particular case, you are told that on cover uncover test, the right eye is fixing, but there is a dominance. How did you say it is dominant? What made you tell it is dominant?
On cover, alternate cover test, we observe the movement of both eyes. That is, and we observe that both eyes takes up the fixation movement. But on uncovering the uncovering left eye, the left eye readily takes up the fixation, which suggests that left eye is dominant.
The other thing is what you have to see is when you close the doing the alternate cover, you should see whether the right eye is maintaining that fixation. So in this particular case, probably as soon as you remove the cover, the eye would have gone into, it won't have maintained to the blink or anything, the right eye won't have maintained the fixation. So we should say that patient is not able to maintain the fixation. Like some people know, they will fixate, minute they blink, the eye will go into ET. So that is how we should know that you know that it is not maintaining the fixation. Suppose this is a child means, then we have to think about risk of amblyopia, because this is an adult, we are not telling. So usually we do not get diplopia in adults, right? Why? Usually usually we don't get diplopia in young children. Why? Because it goes for
Anomalous suppression.
It goes for suppression. So what is confusion and what is diplopia? Confusion is, there is a initial stage is confusion, because both the fovea is getting
one image falls over the fovea and the other image falls on the extrafoveal region.
That is diplopia. Both eye bifoveal is confusion. So the convergent eye is seeing it's taking up the nasal thing. So it is getting, the image is shifted, and the other eye is falling on the fovea, and that is, there is a displacement in this thing. Whereas in confusion, it is foveo-foveal. Both the fovea is seeing different objects, and so you get a confused this thing. Okay, suppose one is seeing a rabbit and the other is seeing something else. Okay, so that is how it happens. And then in a pediatric age group goes for suppression. So in this particular case, you gave one history that near work. So all of us have seen that in this COVID times, a lot of children playing games and all that also triggered acute esotropia. So what are any idea whether you have read on the types of acute esotropia, committed esotropia in adults? Do you know any types in it? If you don't know,
There are traditional classification gives mainly 3 types. A Swan type, Burian type, and Bilshowski's type. In Swan type, it is due to disruption of fusion.
yes.
That is, if there is prolonged monocular vision, it can lead to disruption of
Monocular, even occlusion. So that is why you should be very careful when you give occlusion therapy. You should always ask for follow-up and not prolong occlusion. These days we don't do it usually because previously we used to do 2:1, 3:1, 2 days of occlusion, 1 day of non-occlusion, all that. Nowadays it is always part-time occlusion. So the risk of it is not there so much. But if you give atropine, then this problem can come. Okay. Okay. The second type.
In second type, there is it is mainly due to psychosocial stress mainly, and there is only mild hyperopia and diplopia will be present.
Okay, the third type is what we are seeing now.
Bilshowski's type.
This is
there is due to prolonged near work. It is said that due to prolonged near work, there is instability of both the convergence and divergence, leading to increased medial rectus tension and medial rectus tension increases. There is an increased tone of medial rectus, which leads to esotropy.
Okay. Next slide, you go. So, how does a prism act? So you have put base out. Okay, how does the image deviation of a prism?
On keeping a prism in front of the eye, it shifts the image towards the apex.
Okay. That is what we have to remember. It shifts the image towards the apex. That part we have to remember, and always you should have the 9-gaze measurements. Okay, so here it's a basic esotropia. So you have not given the full 9-gaze, but this is okay for your exams. It is good enough that this thing. So here you can have some, in an exotropia, you can have some lateral incomitance. So one side it may be more, one side it may be less. So what is primary deviation and what is secondary? Because you told diplopia, everything. So did you measure a primary deviation and a secondary deviation and all that in this particular case?
I have not mentioned primary and secondary deviation because from the history and initial ocular examination, it was more suggestive of committant squint. So in committant squint, it will be primary deviation and secondary deviation will be
okay. What is primary deviation? That is
primary deviation is a ocular deviation which is obtained when the normal eye is fixing and the prism is kept over the abnormal deviating eye, and in secondary deviation, it is the deviation which is obtained when the deviating eye is fixing.
Okay. So easy thing to remember is PP and SS. Primary deviation is palsied eye deviation. SS is secondary deviation is sound eye deviation. Right. So why does this happen? So based on law.
It is based on Hering's law of equal innovation. The Hering's law of equal innovation says that on binocular, for a binocular conjugate eye movement, in binocular conjugate eye movement, there is equal and simultaneous innervation to the contralateral synergistic muscle or the yoke muscle.
Okay. So what is duction? What is version?
Duction is the uniocular movement of the eye around the fixed axis, And the versions are binocular, simultaneous conjugate eye movements, which is in the same.
Okay. So in a periodic squint, which is more affected, the adduction or the versions?
Versions. Adductions are more affected.
Versions are more affected. Okay. You first told correctly. Versions are more affected. Adduction, it can this thing. So you have told that this is this thing. So you didn't do a primary and a secondary deviation. Even if you had done, it would have been almost same. Okay? And now that how will you differentiate between you have the 10 points in the exam, they will ask you how to differentiate between a paralytic and a non-paralytic squint. That and all you should know. And 10 points are there, no? It is there in all the books. So you can go through that. Or if you know a few, you can just quickly tell them for the benefit of the other postgraduates who are listening in the program. How to differentiate between a committant and an incommittant squint.
In committant squint, the deviation will be same in all directions of the gaze, whereas in incommittant, it will not be equal. Then in committant squint, the primary deviation is equal to secondary deviation, whereas in incommittant squint, the secondary deviation will be more than primary deviation. Then we can see an abnormal head posture in committant squint, whereas no abnormal head posture noted in committant squint.
Very good.
Usually, committant squint will be seen in children, and other one will be usually acquired. Both for distance and near, it will be equal in.
You cannot say. Okay.
Diplopia will be present in incommittant squint.
So all these things in this particular case, except that you don't have a head posture and all that, and the history is more towards this thing. Otherwise, if you see there is a diplopia, and there is no binocular vision in this particular case, it is, but still diplopia is there. You are saying, next slide you go, you are saying that there is no BSV, right? So you have told that there is no
gross stereopsis.
Gross stereopsis. So what are the grades of binocular vision?
There are 3 grades. Grade 1 is simultaneous perception. Grade 2 is fusion, and grade 3 is stereopsis.
Okay. And how do you test for BSV? Any other than this? Do you have heard of synoptophore or anything like that?
Synoptophore, they work based on the principle of haploscopic principle.
So have you done that? Have you seen it?
I have seen it, but I have not done it.
Good, okay. One time you should do it and see. So what is the normal stereopsis with TNO?
With TNO.
What is the first plate you have written? Did not pass this first screening plate.
There are mainly 7 screen plates for TNO. It is a random dot test.
What is the first one?
TNO, it is.
Have you seen it? Did you try it for yourself?
Yes, madam.
So what is the first one that is there?
It is the moon.
Moona.
Not.
Okay, the children, no. Actually, you can see whether the child is having stereopsis or not, even by the first thing. That startled, they'll get startled if they have really having the stereopsis. They'll get the scare of their lives. Okay, so go back and see.
Butterfly. Butterfly.
Yeah. Okay. So sometimes it suddenly it will just come up. Okay. So, whereas the other one, no, the one doesn't. Which one has monocular clues? One has monocular clues to help us, or PNO has, or Witness has. So this one is better. Always, PNO is better because it doesn't give monocular clues so much. The other one gives us monocular clues, which helps us in this thing. So does a patient with a squint not have stereopsis at all, and he cannot have a depth perception? Is that what it means? Suppose a child is there, 6'6", does that mean the child doesn't have depth perception at all? Both are 6'6". Like you are seeing the child at 10 years of age, there is no stereopsis. And by testing this, does it mean the child cannot perceive depth at all?
Stereopsis usually develops by 4 months of age.
What I am asking you is about monocular clues. I already gave this thing. So they do have depth perception. Okay, but it is not a measurable depth perception, but they all have depth perception based on 7 types of this thing, shades and everything. They can see that there is a bucket with the fluid and this much depth is there, that is perceived. Okay, so this is a theory question, also monocular clues. So this you should know about it. So the other thing is Bagelini striated glass test. What is the angle that is there?
Over the right eye, 135 degree, and over the left eye, 45 degree. It will convert a spot of light into a line, streak of light, and it is perpendicular to the axis of the each eye.
So suppose in the four dot test, you are told that 5 dots is there. Suppose there is only sometimes 3, sometimes 5. What does that mean?
If the patient perceives only 3 dots, it suggests of suppression. If the patient perceives only 3 green dots, it suggests that there is right suppression.
Okay.
If 2 dots, 2 red dots are only seen, it suggests that there is only left eye suppression.
So it doesn't give much this thing, but it is a basic test for checking for diplopia or for doing the binocular vision. So all these things. So what is a horopter?
It is
so horopter and Panam's area. Anything that falls within the Panam's area. Horopter is a line joining all the corresponding retinal points. So it is not a single line. So the area before and in front of and behind, that is called as the Panam's area. Okay, and that is where your binocularity exists. Nothing, it's not a hard and fast rule that this particular point has this. Okay, go to the next slide. Next, yeah, next. So, okay, so this you have done only diplopia charting. So, how does it help in a paralytic squint? A diplopia chart or a Hess chart? How does it help? Why do we do that?
We can look whether it is crossed or uncrossed, depending on the position of the red and light seen. And also, we can look for the separation, in which case the maximum separation is seen.
And then we can see whether there is a tilt and all that, so whether there is any vertical component. So, 3 things we have to see. Okay, whether it's crossed or uncrossed, whether there is any there is a maximum deviation, and whether there is a vertical component to it, or whether there is a tilted. If it is tilted, that means there is a torsional component also to it. So this is a horizontal deviation, so we don't expect all that in this particular case. What is a pseudo-esotropia? Can it happen in this particular case? Not in this case, but in a child it can.
Pseudo-esotropia is the false impression of esotropia, where actually the visual axes are getting aligned. It is seen in broad nasal bridge when there is prominent epicanther fold shows pseudo-esotropia. Or if the IPD is less, also can show pseudo-esotropia.
What is negative angle kappa? Is
Angle
kappa?
kappa. Angle kappa is the angle between the visual axis and the pupillary axis. It is normally plus 5 degree, and
So
and the
sometimes
eye
the macula, when it is shifted or dragged, also you can get this
large angle kappa, large positive angle kappa will be there, and the eye is slightly exotropic.
Suppose in his chart, no, you use red-green goggles once again. Okay, the red filter when you put it over the right eye, that is the fixing eye, and the green pointer, whatever the patient shows, is the deviating the other eye. It is so. How many degrees is it each square? No? In his
5 degree.
So his chart is more useful because you get the number of degrees, so you can measure the amount of deviation, whether it is recovering or not. All that can be done with the his chart, whereas it cannot be done so much with the diplopia chart. So for follow-up visits, whether it is recovering or not, whether the muscle is recovering or not, can be done with the his chart rather than with the diplopia chart. So this only gives you an idea how it is. So coming to the, suppose there is a color vision blind, you told color vision is normal in this case, so we can do his chart. So suppose patient doesn't have color vision, how to test? There is one more test, one more screen.
Lease
Screen, okay, great. So you are told that, okay, so lease screen, which will help in this thing. We don't have lease screen, we also have only his chart. And now it is available in the virtual platform also. So this particular case, they had given, next slide, you can go to, we are told that botulinum toxin. So what are the uses of botulinum toxin in general, in ophthalmology, any idea?
It can be given in essential blephrospasm, hemifacial spasm, for nystagmus, in involutional ectropion. If there is thyroid eye disease, if there is severe dry eye, we can induce ptosis
Okay,
to avoid exposure.
We have never done that. Okay. More this thing, yeah. So
residual deviation.
Residual deviations can be there. And when you inject the botulinum toxin, no? So we can, how do you inject that? How many units? Any idea? And what is the type? The type A, B?
Botulinum toxin type A is mostly used. It is available as Botox, and usually based on the angle, we decide the dosage. That is, if it is less than 20 prism diopter, we can use 2.5 international unit. 20 to 50, we can use 5 international unit in 5 unit in 0.1 ml. And if it is large angle more than 50 prism diopters, we can use 7 units in 0.1 ml.
Okay. So when you give this Botox injection, should we inject directly? And
there are mainly 3 methods.
Yes.
One is open sky technique, other is transconjunctival approach, and the other one is electromyography guided injection of Botox.
The best is EMG. Okay. Otherwise, it is better to transconjunctival. You should be careful. What is the side effect of Botox injection?
Can induce ptosis. Then there can be at local site. There can be subconjunctival hemorrhage. There can be under correction.
under correction. Okay, most of the time it causes other problems. Okay, it can cause mild vertical deviations and ptosis and scare the patient. Only thing is it recovers fast. Okay, so it's the sixth nerve palsy. Where do you give the Botox? Medial rectus or lateral rectus?
In medial rectus.
Okay. Okay. So this is for Botox. So in this particular case, they could have given maybe in both eyes, they could have given Botox. And but the problem was in this particular case, they had given 2 years later, not immediate. So if it had been given immediately, some cases do recover the binocularity. But in this particular case, they have not given that. And you have done squint surgery in the right eye 1 year back. Any idea how much was the amount of surgery that was done?
5 mm medial rectus resection was done and 8 mm lateral rectus resection was done.
Tell it again.
5 mm medial rectus resection and 8 mm lateral rectus resection was done.
So don't get confused over all this. No, eye is in. Yes, so that muscle has to be weakened. That's all. Okay, so medial rectus weakening, recession.
Recession and lateral rectus resection.
So what is the usual how many millimeters from the limbus is the medial rectus?
Medial rectus is 5.5 millimeters from the nasal limbus, and lateral rectus is 6.9 mm from the limbus.
Okay. What is that this thing called as?
Spiral of Tillot's. It is the imaginary line joining the insertion of all the.
Okay. Your mentor has really coached you well. So suppose you don't know how much is the medial rectus recession, how much was it done? Is there any imaging technique which we can use to find out where it is inserted? I'm saying this is a slipped muscle. So can you do some imaging technique to? So
MRI.
you have an MRI, yes, it can pick up sometimes. Yeah, you can ask for it. Or if you have an ASOCT, then that will also pick up where it is attached. So if you are good enough, that also, if it is available, that can be done. So what are the complications of, suppose this particular case, because we are now under only 10 minutes, so we will try to wrap it around. Suppose this case is now coming for surgery, because you still have a 40 prism diopter and we have to do the other eye surgery. So how would you like to do it? Because we have done one eye 5/8 and still it's something like an eating up of prisms. Like once again, it has come to the same level of esotropia. So what would be an ideal this thing? Because we cannot expect what like 5/8 you want to do, but suppose you want to do more, increase or decrease. So what type of squint surgery will you advise in this particular case?
Adjustable suture technique.
Adjustable. We can. Okay. So put the medial rectus. What is that adjustable technique? Any two types you can tell?
Bow tie technique.
The other one?
Sliding coat.
Sliding nose. Okay.
Sliding nose.
Good. Very good. So both the things can be used and we can adjust this thing. And nowadays we do instead of resection, what is the other thing that can be done? To undo the resection also we can do. So what is that called as?
Fadence.
Fadence. Okay, now that you have told fadence, now what is fadence?
It is a posterior scleral fixation. That is the muscle belly is sutured over the sclera beyond the equator.
Beyond the equator. Okay. 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 So, what is the other one for resection? Instead of resection, we can do something else also. That is what most of the
Myotomy. Other is plication, double breasting of the.
Plication is the one that we usually nowadays are switching over. Most of us have switched over to plication instead of resection because it's more safer and we can undo also if you really want to. We can undo it in the immediate post-op period. So suppose you want to do adjustment. Can you do it in the OPD? The adjustable squint. Can you do it in the OPD in the slit lamp or in this thing?
Yes, ma'am.
Yes. So what should you have if you are going to do that? You do it in front of the slit lamp, patient will fall on the floor. So what is it happen?
Ocular cardiac.
What is the pathway? Yeah, what is the pathway? So it's better to avoid.
There is an afferent and efferent pathway. Afferent is 5th nerve and efferent is 10th nerve.
Okay, yes. Okay, super. So how does it go through? Which 5th nerve? What are the nerves that? What is the proprioception through?
Mesencephalic.
Correct. Inga pora nerve ennadu. From here, what is the nerve that is going? What is the nerve supply? Sensory supply for the muscle, this thing. So what are the arterial supply? How many arteries are there for each muscle?
Each muscle have total 7. There is 2 muscular arteries for each, except for lateral rectus. It contains only 1 artery.
So can I do, suppose this case doesn't need, can I do all the 3 muscles together?
It can lead to the risk of anterior segment ischemia if more than 2 muscle surgery is done.
Yeah, I am saying no. Because if you do something, you can prevent that anterior segment ischemia. So what do? We can still do 3 muscle recti, even in younger patient, by doing a vessel sparing surgery. So without touching the vessel, without cutting the muscular vessel, if you do the surgery, then the supply is maintained and you won't get this thing. So the problem is when you are doing an older patient where that's already compromised, then you can go for anterior segment ischemia. And you should know the stages of ischemia. So the earliest thing that can be this thing is a cells. Cells in the anterior chamber is an indication for post-squint surgery. If you have C cells, that means there is an ischemic component there. So that we have to remember till not wait for the pupil to become dilate and fixed. This is the stage 4. Okay, so before that you have to do. So oculocardiac reflex is a very serious thing where it is very common in younger patients and in strabismus surgery because during surgery also you can get that. Suppose you get oculocardiac reflex during the surgery, even during anesthesia, you can get that. And so what do you do immediately?
Atropine can be given.
First release the muscle.
Release the muscle.
Okay, first release the muscle, then you give the atropine. Okay, so first release the muscle and then give atropine. And some people used to, even for a GA, they used to give retrobulbar block. They say that it decreases the oculocardiac reflex. There is a name for that reflex, Ashner or something. I'm just checking.
Ashner. Yes, Ashner only.
Ashner. Okay. So that also can be asked. Okay, oculocardiac reflex, and it is through the long ciliary nerves. Okay, nerve supply and all, you should be thorough. Okay, all those things, pathways and other things, you should be very thorough with this. So what is the most common, one of the common complications of strabismus surgery? During surgery.
And globe perforation is a risk.
Yes, globe perforation.
Lost.
lost
Then
muscle.
lost muscle.
Yeah, you also feel lost after the last one. You lose the muscle. So this can happen when the medial rectus is very tight or something like that. You can, or your assistant, you have two assistants to hold for a single muscle, it can snap. Okay, or in like DRS also, you can get a tight muscle and it can snap. So globe perforation has occurred. What will you do? You immediately do a indirect ophthalmoscopy. Just confirm if it is really there. There is a globe perforation. If it is there, you just have to barrage it the next day. That's it. Okay, and you will be saved. Okay. Only thing you should, as soon as you have a suspicion, you should get a retina consultant to help you with it too. So the other thing with all these complications, you should always say starting from pre-op, intra-op, post-op. Okay. And so in this intra-op, you can have not only globe perforations. If you are too much dissecting of the tissues and you go beyond the equator, then you can have fat prolapse. Then it leads to unnecessary adhesions and all that. So the dissection should be clean and neat. You would have seen Samyukta operating, AP operating. It will, that is also this thing. And the late post-op complication, the later post-op complication is your, once again, the persistence of the deviation that or over and under corrections. That's important that you manage that. I think we have only another 4 minutes to wrap up. I think this was a wonderfully, you really did a good job. You are read up, so read the whole squint to some extent. You have done the reading, so lots more to learn from each this thing. I'm very happy that Samyukta gave you this case, and we do get acute EPs. If they come to us immediately, we do give Botox if it is less than 20 prisms, 25 prisms, and then otherwise we go ahead with the surgical intervention. And we have case reports and case series also, which has been accepted. I mean, which has been published in IJO. You can go. Yukta, you want to add something?
Covered really well, madam. Yes, Mushrika, what is the principle of diplopia charting? Can you throw some light on that? Principle of diplopia charting?
A single image is perceived as two perceptual image.
When somebody asks you a specific question like what is a principle, what will you say? Based on the principle of dissociation. Dissociation. That is, and what is that goggle named as? What is the name?
Armstrong goggles.
Okay, we don't have a HES chart here, but they might ask you what is the torch which is used for that? What is the name of the green torch which we use? Foster torch. What else? Madam, Dr. Marian Polly, madam has joined. She is our member of the scientific committee.
Good evening, madam.
Hi, I was actually listening to half in YouTube and later I joined in this Zoom. It was a very nice discussion, like, lots and lots, everything has been covered. So I really thank Dr. Meenakshi for joining with us today. This is our initiative of teaching PGs through online, happening once in 2 weeks in a Zoom platform. So thank you so much, madam, for taking time out and to spend some time with our PGs. I thank Dr. Samyukta, the mentor, and Dr. Usharipa, the student, who was presented very nicely. And special thanks to Dr. Samyukta. She has really mentored her student very well because she was answering everything, almost everything.
Yeah, she answered. So this is only a basic discussion. We don't want to, they have to know this much at least to, so that they know to manage the patient, when to refer, when to this thing. Okay. One important thing is neuroimaging, which you have done. So that's very important that in an acute ET, even though you suspect this, neuroimaging has to be done. Okay.
So thank you so much once again from on behalf of KSOS.
Thank you,
Thank you,
Aishu.
sir.
Thank you
Thank
for
you very
giving me
much.
this opportunity. Thank you, Samyukta. Thank you.